Welcome, everyone. Thank you very much for listening to this lecture around the unstable shoulder. My name is Anju Jaggi. I'm a consultant physiotherapist, and I've had over 25 years experience of managing patients with chronic persistent shoulder pain and instability. I'm currently working at the Royal National Orthopaedic Hospital. We're based in northwest London, and I'd like to share my clinical experience, some of the research that we've been doing, particularly in patients with non-traumatic shoulder instability, over the next half an hour or so. So I hope you enjoy. So there are numerous classification systems out there, and the Stanmore classification is one that has become popular over the last few years, and obviously something that we've adopted at the Royal National Orthopaedic Hospital based on our understanding of the unstable shoulder. But what I would like to say is that with these classification systems, the frameworks have generally been based on a very biomechanical model. Most commonly, this type of problem occurs in the young male contact athlete. We do see another peak of this type of injury in the older female patient cohort, and that's often as a result of falls where the shoulder has ended up with a fracture dislocation and sometimes can result in also some nerve injury. Obviously, as women engage in more contact sports, we may see an increase in women presenting with this problem. These patients will sometimes describe a party tricking history, so they may have been able to demonstrate that their shoulder can sublux, and they usually would have had voluntary control, but then can go on to develop an involuntary problem where they then describe that now the shoulder displaces or feels apprehensive even without them initiating a party tricking movement. This algorithm is published in the British Elbow Shoulder Society guidelines. There was an algorithm to basically sort of guide the clinician on what to do for the sort of uncomplicated traumatic anterior dislocation. Most commonly, we have the apprehension test, which is usually done in a supine position. You're provoking a feeling of apprehension by placing the arm into an Aber position. As soon as the patient is placed into this position, if they feel anxious or worried, then the test is deemed positive, where the patient is clearly exhibiting feelings of positive apprehension. But what's really important is to also assess the muscular function, because being lax itself is not necessarily a cause for instability. And people can be very, very lax, but if their muscles are good and strong, they can manage their stability very well. When it comes to management for these patients, when we're looking at the traumatic group, a lot of the decision making is really dictated from a surgical perspective on the dependence of kind of soft tissue versus bony damage. So surgical management, I think it's not absolutely arbitrary, but in that sort of non-contact player where there really isn't a lot of bony damage, they've perhaps had a first-time dislocation, there may have been the odd recurrent instability, but they're not going to be performing in terms of very high collision sports, then an arthroscopic stabilisation repair would be adequate. A few trials that have come about, and the Artisan trial, which is now completed and is awaiting publication, they took patients in the UK who'd had a first episode of dislocation through trauma, and these patients were then given one session of physiotherapy advice versus a course of physiotherapy, and this was a multi-centred trial, and they looked at the recurrence follow-up at 1 year. Now the results are imminent, but essentially it showed that if you give these patients some good advice early on post-dislocation, it seemed to be just as effective as giving them a course of physiotherapy. When it comes to what are the physical parameters with regards to getting people back to play, again, there is no real consensus. There are several tests that can be used, such as the Y balance test, the ASH test, looking at the amount of force generated through a force plate. And I've put here in the talk the SARTS battery test that's been described by Margie Olds out in New Zealand as looking at trying to help to decide when patients are ready to get back to contact sports. And she's got a nice podcast which you can listen to here in the link. Historically, this group has really been managed with an exercise program, and this was based on the work done by Birkhead and Rockwood, where they took 140 shoulders and 150 patients. And these were patients who both had traumatic and atraumatic predisposition. And they were given this Rockwood program, kind of phase 1, strengthening with TheraBand progressively through different degrees of abduction. And then phase 2, where they were then doing resisted weights and pulley systems and weight-bearing exercises. When it comes to our personal experience at Stanmore, being a specialist unit, we see patients who have either received about 90% of patients will have received physiotherapy prior to coming to us, and are still struggling with their symptoms. Our cohort generally tend to be more female than male. One of the factors we think due to them having ongoing issues with their shoulder is that this is often associated with Ehlers-Danlos syndrome and joint hypermobility spectrum disorder, and therefore the shoulder is not only the only joint that is affected. Important, therefore, when you're seeing this more challenging group, to assess for not just laxity at the shoulder, but more generalised hypermobility, and perhaps it may be important to be seen by a rheumatologist as well, just to check that they don't have a spectrum disorder, hypermobility spectrum disorder. So I would also assess for laxity at the thumbs, the metacarpal joints, the elbows, knees and hands to floor. Some further work that we've done was that we were particularly interested at looking at the psychological comorbidities of patients with non-traumatic shoulder instability. So this includes the type 2 and type 3 on the Stanmore classification. It was actually quite stark, and we found that the prevalence of depression in our cohort was at about 35%. And the UK incidence at that time was sitting really at about 4 to 10%. So there was a significant prevalence of depression in this atraumatic cohort. But what's really important is that returning these patients back to play is reducing their fear, improving good motor strategy and recruitment, and making sure that rehab is functional towards the end stage to get them back to the level of what they wish. Thank you very much.